Good evening, everyone, and welcome to this webinar by Wu University called the ABCs of ADCs with Dr. Saba Al-Hashimi. Next slide. I'm Dr. Elise Kramer. It's so nice to have all of you. It's a huge honor for us to have you, Dr. Al-Hashimi. Thank you so much for being here with us, and really looking forward to learning from you tonight, and I know our attendees as well. And I'd like to introduce our amazing speaker. So Dr. Saba Al-Hashimi got a Bachelor of Science, Biological Sciences from University of California, Irvine, Doctor of Medicine from Virginia Commonwealth University. He did his internship at Olive View Medical Center, UCLA, his residency at Boston University Medical Center, fellowship at Steinite Institute at UCLA, and now is an assistant clinical professor of ophthalmology since 2017 at UCLA. We have the financial disclosures, and all financial relationships have been mitigated. So without further ado, Dr. Saba Al-Hashimi, please take it away.
Thank you. Thank you for that. And thank you for inviting me to give this talk. I appreciate you all being here on this Friday evening. I'm sure there's a lot of other things you can be doing on this 3-day weekend. And so I'm hoping that by giving this talk, you'll become a little bit more familiar with the ADCs. I was very proud of my title, the ABCs of ADCs. That's probably the most clever thing in this talk. So hopefully you appreciate it. So as an overview, we're going to talk about a couple things. One is what are ADCs, and then the ocular adverse events associated with ADCs, and then how to manage those ocular adverse events. And then we'll finish off with a little bit of a discussion. So let's start with what are ADCs. Now, last week at Wu University, an oncologist gave a great lecture kind of introducing ADCs. I'm not going to go as in depth, but I think it's good to have an overview. So ADCs have been around for over a decade, but they represent a newer class of this antigen targeting therapy. So basically, there's a highly potent antibody-based therapeutic that consists of 3 different parts. So the first part is a monoclonal antibody that targets a very specific antigen on cancer cells. And then this is attached to a cytotoxic payload, which then kills the cancer cells. And this is attached using a chemical linker that connects the drug to the antibody. And this allows a very specific way of delivering exactly to the correct place the cytotoxic payload, and it decreases the cytotoxic effects for the rest of the body. Another less well-known advantage of ADCs is that it also allows a significant increase in the half-life of the drug from just a few hours to over a few weeks by conjugating the agent to the antibody. And this increases the therapeutic window substantially. So in this cartoon diagram, you can see kind of the mechanism of the ADC. So first it binds to the specific antigen on the cancer cells, and then it's internalized by endocytosis. And then inside of the lysosome, the linker is degraded and the payload is released. And then that essentially disrupts the cell and causes apoptosis. So in this figure here, it's through microtubule disruption, which is kind of one of the more common ways that these ADCs work. So currently, there's about 12 FDA-approved ADCs. For those of you paying attention, there's actually 13 listed here on this slide. But I'm going to highlight one here called belantamab or Blenrep, which was FDA approved in 2020, but actually just recently withdrawn November 22nd of 2022. And the reason why was because it didn't meet its primary endpoint of superior progression-free survival compared to standard of therapy, which is Pomdex, a combination of polimodide and dexamethasone. So in addition to these 12 currently approved ADCs, there's over 100 that are in clinical trials across different tumor types, ranging from solid tumors to blood-borne cancers like large B-cell lymphoma. And why it's important for us is because there's ocular adverse events associated with a lot of these ADCs. In fact, 3 of them have a black box warning attached to them. Blenrep, which you can see at the top here, which again was withdrawn, but FDA approved in 2020. And then 2 others, Tivdak and something called MERV. And these treat different types of cancers, but they all seem to have some level of ocular toxicity. With Blenrep, there's this unique REMS requirement or risk evaluation mitigation strategy. And we'll talk a little bit more about that in some later slides. But essentially, with these infusions, it's essential that there's an eye care provider as part of the team in order to kind of assess for these ocular toxicities and help guide the oncologist on what to do. And so, like I mentioned, these ocular toxicities have been reported with increased frequency in these ADCs, and specifically those that utilize a tubulin inhibiting cytotoxin. So some of the more common ocular toxicities observed over 22 different citations included blurred vision, which seemed to be the most common, dry eye or keratitis, and then corneal abnormalities. And these corneal abnormalities ranged anywhere from mild to vision threatening. And uniquely, they're characterized by these microcyst-like epithelial changes, or MECs. And this was something that I had never seen before. This is an example of a slit lamp exam showing the MECs. It's a little bit subtle, but you can see kind of depicted by the pink arrow that you've got these little clusters of clear vesicles basically in the epithelium. They tend to start kind of in the periphery and then migrate centrally towards the pupil. And to the best of my knowledge, the exact mechanism causing these changes is still under investigation and currently not known. It may be related to nonspecific uptake into these kind of more rapidly dividing epithelial cells, which then causes apoptosis and produces these microcysts. Blenrep is actually still being used in compassionate settings, but again has been withdrawn from the market. But I think this was one of the ones that really caught the attention of eye care providers and was actually the first ADC that came into my practice. And so it's gained a lot of interest since its approval again in August of 2020. Here are just a couple other slit lamp photos, again depicting those fine microcysts. They're subtle, but they're best visualized kind of with intermediate to high magnification and using retroillumination off the iris or indirect illumination, things like sclerotic scatter. The cysts don't actually stain, but as the toxicity becomes more advanced, you can start to get coarse punctate staining. And so it's still important to instill fluorescein dye and use a cobalt blue filter when you're examining these patients, but the dye and the filter are not going to actually help highlight these cysts. And these cysts have also been investigated by confocal imaging. This is one example to kind of better describe these unique microcysts. And so on confocal, you can see these hyperreflective opacities within the corneal epithelium. They're more prominent in the wing cells as seen in image D and in the basal cells in image E compared to the more superficial cells in image F. And so sticking with this specific ADC, belantamab or Blenrep, the DREAM2 study was an open label phase 2 study that was 2-armed and used to kind of determine both the safety and efficacy of this specific ADC. And so they specifically looked at ocular adverse events and graded them through an eye provider. And this is kind of what the grading scale looked like here. So with grade 1, you would either see mild superficial keratopathy, so peripheral mild staining or maybe faint resemblance of some microcysts. With grade 2, you start to see more moderate superficial keratopathy. These cysts are now located kind of in the mid-periphery. Or you could have a decline of baseline vision from 2 or 3 lines, but not worse than 2200. And then with grade 3, the severity, of course, is getting worse. These cysts are now in the visual axis, and there can be a decline of more than 3 lines of vision, but not worse than 2200. And finally, with grade 4, we're talking about epithelial defects and corneal ulceration or visual acuity worse than 2200. So this study took place over 58 different multiple myeloma specialty centers in 8 different countries and included 196 patients. And these were the study results in regards to the incidence, duration, and resolution of corneal signs and symptoms in this study. So the most common adverse event noted were these microcystic changes, and these developed in about 72% of patients, highlighted by this arrow here. In my experience, I've seen about maybe 15 of these patients now. If the medication is given long enough, I've seen these microcysts in every single one of my patients. So I think the incidence is probably a little bit higher. You can see in this table that the median time of onset to developing these MECs is about 37 days, which is really just after 1 or 2 infusions, because the infusions are usually given every 3 weeks. So that happens pretty quickly. And at the time of the data cutoff, 77% of patients had recovered from their first occurrence of grade 2 MECs. So a lot of these patients will recover their vision, and the MECs kind of go away when the infusions are stopped. The median time to resolution from the first event of MECs is about 86 days. So it takes a really long time for those to go away. And the peak recovery happens around 2 to 6 months post-treatment. But it's important to note that recovery of vision is actually much faster. So the median duration of blurred vision is about 33 days. And even more importantly, in those patients that have infusions held because of these ocular AEs, they found that they didn't actually have progression of their disease, of their multiple myeloma. And in fact, many continue to even improve beyond, even with skipped cycles. And this is potentially related to, again, the long half-life of ADCs. So, basically the things to take from this slide in regards to this specific ADC are that the microcystic changes are very common. They happen relatively quickly after starting therapy, and they can take a few months to resolve from time of onset, but the majority of patients seem to recover. So the next ADC I'd like to touch on is called Tivdak. This is indicated for the treatment of recurrent or metastatic cervical cancer. And again, this is one of the ones that is associated with that black box warning from the FDA label. And you can see that the majority of the eye disorders were grade 1 or 2. And the most common thing was actually conjunctival adverse reactions. And these included things like non-infectious conjunctivitis, conjunctival erosions, conjunctival hyperemia, or even conjunctival hemorrhages. The corneal adverse reactions included things like keratitis, punctate keratitis, ulcerative keratitis, and they listed corneal bleeding as one of the adverse events. As a cornea specialist, I've never seen a cornea spontaneously bleed. I would have loved to have seen what that looked like, but that was also one of the things that apparently was reported in the adverse events. And then in terms of the periorbital adverse events, it's mainly talking about the eyelids. So things like blepharitis, meibomitis, eye pruritus, and trichiasis. So kind of looking at overall the adverse events associated with Tivdak, 60% of the patients basically had some kind of ocular findings, signs or symptoms. Grade 3 ocular adverse events occurred in about 3.8% of patients, including severe ulcerative keratitis in 3% of patients. The median time to onset from the first ocular adverse event was 1.2 months. So again, happening very early after starting these infusions. And this led to discontinuation of Tivdak in 6% of patients. And so usually discontinuation means that they've reached a level like grade 4. But again, what's important to understand is that at the last follow-up, 85% of patients who experienced ocular adverse reactions had either complete resolution, 55% of them, or at least some partial improvement, which was defined as a decrease in severity of 1 or more grades from the worst grade. So the last of these 3 that have a black box warning is this medication here called mirvetuximab, or MIRV, as it's also known. And this is for platinum-resistant ovarian cancer. And the study was called Soraya. This was a phase 3 study. Similarly to Blenrep, patients with MIRV received a baseline exam from an eye care provider. So all patients had a baseline exam. And then ocular symptoms were assessed by the investigator, so the oncologist at each visit. So they would ask him things like, how are your eyes feeling? Are you noticing any vision changes? And in patients with any symptoms, they were then referred to see an eye care specialist for evaluation. And for those who did experience ocular adverse events, eye exams were then conducted every other cycle until resolution, stabilization, or return to baseline. So they recruited over 100 patients for this trial, and they tried mitigating some of the ocular adverse events by requiring the use of topical steroids 6 times a day on days 1 through 4, and then 4 times a day on days 5 through 8 of each cycle, as well as the use of preservative-free artificial tears. So even with these mitigation strategies in place, about 55% of patients still developed ocular adverse events. The most common was blurred vision in about 41% of patients, and then keratopathy in about 29% of patients. 6% of patients experienced grade 3 blurred vision, 8% experienced grade 3 keratopathy, and 1 patient experienced a grade 4 keratopathy defined as vision worse than 2200, but this improved within 15 days back to grade 0. So again, the onset of these adverse events happened relatively quickly, with the median onset to blurred vision being 1.3 months, and keratopathy being at 1.5 months. So let's take a patient case example from this MIRV study. So this was a 56-year-old woman with ovarian cancer that was treated with MIRV. At baseline, her ocular examination was normal. And then 5 weeks into therapy, which was around cycle 2, she presented with complaints of vision changes. And then upon evaluation, she was found again to have these microcysts, similar to the ones that develop in Blenrep. And here you can see where these arrows are depicting those subtle microcysts. So what's interesting is the patient also exhibited central corneal flattening on topography, which you can see on the left side there. This was associated with a hyperopic refractive shift of about 1.5 diopters. So the patient remained on MIRV and was started on Tobradex drops, and then noted improvement in symptoms within a week. And within a month, her ocular examination returned to baseline, and you can see the topography had essentially normalized. Okay, so how do we manage these ocular adverse events? We know that these are going to be pretty common, it seems, with these ADCs. Well, with Blenrep, like I talked about previously, there's this REMS strategy, or risk evaluation and mitigation strategy. And basically, the eye care provider was essential. So there's a baseline exam that's performed prior to the patient starting the infusions that's mandatory. And then with each subsequent infusion, another eye exam is required before the patient can get the infusion. And the reason why was because dependent on how the eye exam was graded, the oncologist would either continue the same current dose of infusions or start to make adjustments. So with grade 1, either keratopathy or blurred vision, you could continue at the same dose. With grade 2, you would have to then hold the Blenrep infusions until things improve to grade 1 or better, and then you could resume at the same dose. With grade 3, you would have to hold again until grade 1 or better, but then you would restart the infusions at a reduced dose. And if they did develop grade 4 findings, then there was a consideration of actually discontinuing the Blenrep infusions. This is what the first page of the REMS evaluation looks like for the eye care provider. So basically, all that's required is really a best corrected visual acuity for baseline. You know, it's still important to kind of assess the ocular surface and make sure that it's intact and healthy looking before starting the infusions, but it didn't disqualify patients if they already had some type of ocular pathology. Section 2 deals more with the follow-up examination. So again, what are the best corrected visual acuities? And then there's check boxes for if there was any findings on exam. And so you would just check kind of mild, moderate, severe, and what their decline in vision was. And then based off of that, on section 3, you would then grade them. And again, it's important to realize that you may feel guilty giving them a higher grade because you're worried that they're not going to be able to get this life-saving infusion when it's supposed to be scheduled. But again, keep in mind that at least for Blenrep, the data suggests that even when doses were held or reduced, that patients still seem to do really well. And so you should really try to grade these honestly so that it doesn't spiral out of control and end up at grade 4, which may lead to permanent consequences. This is the MERV ocular assessment form that's also, again, mandatory. And so you fill this out and then submit it back to the oncologist. It's very similar, but also includes an evaluation for uveitis, which was noted, I think, in a very small minority of patients. So some of you may be thinking that topical steroids seem to be having some benefit, especially given that case presentation example that I showed. And in fact, 3 out of the 22 references did report some benefit in patients using topical steroids in regards to these corneal AEs. One was actually associated with a reduced incidence when it was used prophylactically. But these have been kind of poorly studied, and honestly, I don't think that they seemed that promising. And the reason why is based off of an ocular sub-study of the DREAM2. And so in this ocular sub-study, there was 30 patients, and in one of the eyes, they would prophylactically dose with corticosteroid drops. I believe it was dexamethasone 0.1% QID. Both eyes would still use preservative-free artificial tears, but only one of the eyes would have corticosteroid drops. And basically what they found was that there was no difference in the median time to keratopathy onset or in the number of patients that developed grade 3 keratopathy. So no statistical difference between the treated and the untreated eye or the onset of the keratopathy. And so from this ocular sub-study, they basically concluded that steroids are ineffective. So that's a little disappointing to hear. But what has been actually found to be helpful is just preservative-free lubricating drops. So this was a phase 1 trial with MERV, the first in-human study with this medication. And you can see that the number of grade 2 events in blurred vision was reduced after starting the use of artificial tears, and also with the keratopathy. So there was actually no grade 2 keratopathy. With the blurred vision, of course, more grade 1 blurred vision was noted, but again, less grade 2. And as long as they're staying at grade 1, then they can continue the infusions. So, what else can really be done? I don't really know. I think until the mechanism is better understood, we don't really have a good strategy. Some of you in the audience may be wondering if the Procara could potentially help. I've tried this. I've got an N of 1. I tried it once in a patient who had bilateral MECs that were grade 3. And so I placed the Procara in one of the eyes and saw the patient back a week later. The membrane had kind of melted away. I removed the ring and the MECs were still right there. It looked no different and very similar to the other eye that I had not placed a Procara lens on. So I don't think that this is really going to be a way of succeeding. Bandaged contact lenses have been investigated, but they also have not been reported to be of any benefit. And with some of these infusions, there's actually a protocol to use cooling masks and vasoconstrictors like phenylephrine during the infusions. They don't really seem to make a big impact either. The thought behind the cooling mask and vasoconstrictors is that if you can constrict the blood vessels that are feeding the epithelium, that potentially you could reduce the amount of toxicity that's being delivered to the eye. But again, I think that because the ADCs are hanging around for so long, these kind of temporary measures are not really panning out here. Now, there are active studies looking at autologous serum tears, and there are some anecdotal reports of success. And I do think that this seems a little bit promising. I did pull just one case series report here of another ADC that's used for HER2 cancers. And these patients, there was about 3 patients who developed limbal stem cell dysfunction. And they tried steroids and tried artificial tears, and that didn't really seem to do anything. And so they gave these patients autologous serum tears, and all patients basically improved and the limbal stem cell dysfunction resolved. And so, I think that this is still an avenue that potentially needs more exploration. So finally, going into our discussion, what are the ocular adverse events associated with ADCs? Well, there's many. The most common certainly seem to be blurred vision, keratitis, dry eye, and these microcystic changes. But there's a whole gamut of things, including, ocular bleeding, again listed here, uveitis, and cortical blindness was even reported. I don't know if these are truly associated with the ADC or not. So why does this happen? Again, we still don't really know. It's either a direct or an indirect delivery of the payload to the epithelial cells that's then causing necrosis. So, while the cornea is an avascular structure, the corneoscleral limbus is highly vascularized, and this supplies the region where the limbal stem cells can be found. And potentially because of the high cellular turnover, corneal epithelial cells are constantly replenished at the limbus, and these rapidly dividing cells may be more vulnerable. So it's either an on-target antibody-mediated delivery or an off-target delivery of the unconjugated cytotoxin. And these linkers have definitely evolved and have gotten better so that they are not, again, causing this collateral damage. But I think until we know the exact mechanism of what's causing these adverse events, specifically these microcystic changes, which are quite unique, I think it's going to be challenging to develop a mitigation strategy. So what will the patients complain of? Mainly dry eye and blurred vision. They may be light sensitive, or they may have monocular diplopia because of changes in refraction and irregular astigmatism. But what I've experienced so far is mainly the complaint of blurred vision, less so of dry eye. But these are the things to kind of ask the patient about. And then what should eye care providers look for during an examination? Again, an objective change in vision, so measuring the visual acuity, worsening dry eye or keratopathy, and specifically these microcyst-like epithelial changes. In terms of what diagnostic tests should be done, it's pretty simple. Best corrected visual acuity, so perform a refraction every visit. And the reason why is because the refraction will commonly fluctuate, and so will the visual acuity. But as long as the best corrected visual acuity is similar to baseline, then the treatment can still continue. And the other thing is, of course, the slit lamp exam. Once the epithelial cells are, or the epithelial cysts are involved in the mid-periphery or in the center in the visual axis, then at least for Blenrep's guidelines, the infusions need to be held. So, in the future, other guidelines may suggest differently, but that was the case with Blenrep. So, how should you manage these patients? The treatment algorithms are still evolving. In general, with ADCs, the infusions are given about every 3 weeks or so. And so an eye exam is performed within 3 weeks of the first infusion, kind of as a baseline exam. And then the follow-up exam should be at least a week after the previous dose and within 2 weeks of the next dose. I tend to try to do it either on the same day they're supposed to get the next infusion or the day before they get the next infusion to give them more time to potentially recover. And then preservative-free artificial tears are really the best thing that we have right now. So, all these patients on these ADCs should be frequently lubricating throughout the day and even after the last infusion for 30 days afterwards. And then again, studies with the autologous serum tears seem promising. One question I have is if the drug is being infused and then you take the blood of the patient, then potentially you have the drug in that blood and you're spinning it down into an eye drop and putting it back in the eye. So that may not work out. But there are some studies where the blood is being drawn before the very first infusion. And so then you have drug-free blood that you can spin down into autologous serum tears. And potentially these kind of nutrients and growth factors can help prevent these vulnerable cells from dying off. And so lastly, communication with the hem-onc team is critical. They're depending on the eye care professional to give them the feedback that they need to then determine whether or not it's safe to proceed with the next infusion or whether or not it needs to be reduced or held. And of course, communicating with the patient and asking the patient to communicate with you. And so, if they're noticing any blurred vision or eye symptoms, then they should be able to reach out in order for you to evaluate them sooner. And so I'll typically on my baseline exam, discuss with the patient what they should expect and what to be looking out for. And that way everyone's kind of on the same page. And what's nice is that with all our electronic medical records now, it's a lot easier to kind of communicate with the oncology team as well. Any questions?
Perfect. Thank you so much. That was awesome. So let me just see here. So yeah, if anyone has any questions that we don't get to tonight, definitely send an email. Thank you for putting your email up there. I really appreciate that. If you can go to the next slide quickly. We also have an amazing CE event coming up, which is going to be on February 7th from 5:30 p.m. to 6:30 p.m. Pacific time. And this is going to be about clinical tips for successful contact lens practice. So definitely don't miss that. While I answer or ask questions, I'm going to share this QR code, which again, you can use your OE Tracker app in order to get your instant credit. But either way, don't worry, because you will get those by email. So let me go through some of the questions here. Done. So if you're using serum, the blood is drawn prior or post-treatment.
Yeah, I mean, I think it makes more sense to consider drawing the blood pre-treatment, pre-infusions, just so that you're not taking the ADC with the blood. Mm-hmm. And again, there are some clinical trials investigating this approach. But to me, in theory, I think that makes a little bit more sense than drawing the blood after the infusions have started.
Mm-hmm. And are ADCs used for anything other than cancer treatments?
That's a great question. Not that I'm aware of. I mean, if you think about what the ADC is doing, it's targeting an abnormal cell and destroying that cell. And so these abnormal cells have these, unique antigens on them that the antibody can attach to. I'm trying to think of any diseases where there's abnormal cells that you would want to target. But the first thing certainly that comes to mind is cancerous cells.
Mm-hmm. And do MECs always stain?
Actually, they never stain. So the MECs themselves don't typically stain. They just look like they're right in the epithelium, essentially. But as the keratopathy worsens, you'll start to get coarse punctate staining in addition to the MECs. So the MECs themselves don't stain, but you can have staining on exam.
And have you tried punctal occlusion to increase tear volume while managing some of these patients?
So I have not. And again, it's because I'm not exactly sure where the toxicity is coming from. And I don't really understand why artificial tears really help, to be honest. And so if artificial tears are helping, potentially it's just flushing out the tear film, right? So you're substituting the tear film with these lubricating drops. And so I worry that punctal occlusion will just allow the tear film to stay in the eye longer, on the ocular surface longer, and potentially that's where these adverse events are coming from the tear film and not actually the blood. So I have not tried that.
Okay. Have you seen any posterior findings? There was one reported vein occlusion, and one of our attendees said that they think they have 2 vascular occlusions with ADC patients.
Wow. So I have not seen posterior findings. I am aware of that one reported vein occlusion. I mean, you can think that these patients are very sick. A lot of them have a leukemia or a multiple myeloma that I think already increases their chances of having a vascular event. So I'm not certain whether or not the ADC itself is contributing to these vascular events, or if it's just, the nature of their comorbidities.
One of our attendees was talking about doing a study with one eye, one group doing Tobradex, the other with one eye treated and one not treated, and wonders about what about cross-contamination and patient error, possibly systemic absorption of the steroid in that study, in a study like that?
Yeah, I mean, I think there's always that potential, and you know, I think that using the other eye is a great way of doing studies to kind of compare in the same exact patient. But certainly, to make it cleaner, you could just have separate cohorts of patients to negate that effect. I mean, I don't think that you know, a low-dose steroid used 4 times a day is going to have too much of a systemic impact or translate to the other eye. And again, in the Blenrep study, they really didn't see any significant difference between the 2 eyes.
Okay. And what's the rationale behind using Tobradex? Would steroids alone be sufficient?
Yeah, so
I use the antibiotic combo in that case.
That's a pet peeve of mine. So for all of you out there, whenever you're just trying to use a steroid, don't add the antibiotic to it. I think it's just adding more toxicity to the patient. So certainly we have steroids that aren't combo drops, and I completely agree. I think unless there was an epithelial defect or something else that required coverage, I think it's definitely cleaner to not use something like tobramycin with the dexamethasone.
Has anyone tried Miro 128?
I have not tried. I don't know if anyone has not tried. I'm not sure what the Miro would accomplish. Again, that's just going to pull fluid out from essentially the epithelium. But these microcystic changes aren't related to swelling of the epithelium necessarily. And so, you know, it's interesting. I think that someone should try it, but I have not.
Are there any ADCs for ocular tumors?
Not to the best of my knowledge, not yet. But I do think that that would be great. You know, ocular melanoma and conjunctival melanoma is still a very difficult thing to deal with. I think, you know, for the OSSN type of cancers on the ocular surface, we have pretty good treatments now with 5FU. We used to have interferon, we're not able to get it anymore, but 5FU is still great. And then just being able to excise the tumor surgically, you know, is still the gold standard. I would not think that they would want to pursue infusions of an ADC that may have kind of systemic issues. You know, we talked and focused mainly on the ocular adverse events, but there are certainly a lot of systemic events that happen as well with these medications. You know, things like nausea, vomiting, GI distress, and so on.
What about LED low light therapy or Regenerize? Has that been used?
Not to my knowledge. You know, I think that the Regenerize approach is an interesting thing to consider. But again, with my N of 1, using a Procara lens, which I think is a little bit more substantial potentially than Regenerize, I didn't really see any improvement after about a week. Mm-hmm. It's a reasonable thing to pursue. I think one of the challenges when trying to design these studies and then potentially initiate these protocols is that how are you going to get this to every patient? You know, serum tears, unfortunately, are still not covered by insurance, neither is Regenerize. And so it ends up being kind of a financial burden as well. So certainly can be studied, but neither of those therapies are currently FDA approved.
One of our attendees said that they've had a couple of Blenrep patients that remain grade 2 after holding 2 infusions, and want to know how long in your experience does it take for the cornea to improve with HeldMed?
Yeah, so according to the data from their DREAM2 study, the median time to resolution was about 86 days. So it takes a really long time. That's a great question. And it was something that I struggled with because I felt pressure from the oncology team to hurry up and say the patient's grade 1 so they can start infusions again. But these MECs are pretty stubborn. Usually you'll start to see clearing in the periphery first, and then it kind of migrates forward. The epithelium is turning over basically every 9 days or so, but these MECs seem to last a lot longer than that. And again, probably related to the ADC's half-life, causing some disturbance with the stem cells at the limbus. So, I still see these patients basically every 3 weeks. And, one piece of advice maybe I'd give is that if there is a patient being enrolled and is coming to you for these examinations, the best thing to do is schedule a couple appointments out. So don't just have them keep returning in 3 weeks and scheduling their very next visit, because you eventually end up getting overbooked, and it becomes complicated to try to fit these patients in, because it does take time, and it's quite time intense to kind of see a patient every 3 weeks for potentially months.
Mm-hmm. Are ADCs used for any rheumatology treatments?
Not that, again, that I'm aware of. I'm trying to think if there is potential with that. Probably outside of my area of expertise, I would say.
And are any of the side effects also seen with the use of non-ADC cancer treatments?
So I don't think these MECs, these microcysts, have really been seen with anything other than these ADCs, which I think is why, we as eye providers have found them so fascinating and interesting to kind of investigate and study further. I've seen plenty of other side effects from chemotherapy agents and other drug toxicities, but these MECs seem quite unique, to be honest, not like anything I've ever seen before.
Do the MECs show a whorl pattern?
Not really. They kind of cluster together, again, starting at the limbus, but they don't whorl the same way, limbal stem cell deficiency does. And so usually they'll start in 1 or 2 areas in the periphery. It's not like they're uniformly all around the limbus and then marching forward. Kind of start temporally or nasally and maybe a little bit inferiorly as well. And then it just kind of becomes more and more prominent as time goes on. But yeah, I don't think that they look whorly in my experience.
Do you see pigment changes? One of our attendees says that they have a patient where they're starting to see pigmentation of the cornea.
I have not. Again, I've seen about 15 patients, so not that many, but I don't think that I've seen any pigmentary changes to the corneal epithelium.
And it looks like we have one more question here. Are there any strategies for managing transient refractive changes, such as maybe scleral lenses or something else that you recommend?
Not that I necessarily would recommend, but I do think that, scleral lenses may be another way to potentially mitigate some of this toxicity if it is in fact coming from the tear film. So, by wearing the scleral lens, you're essentially protecting the cornea from exposure to the tear film, at least part of the day. And yes, it could certainly help mitigate some of those refractive changes that may be causing some of these patients difficulties. But usually it's not like a grade 2 or grade 3. If they're starting at a 2020 baseline, is 2040 or 2050 or maybe 2060. Certainly disruptive, but again, in the context of who these patients are, I mean, these are patients that are essentially dying and have a lot of other comorbidities going along with them. So they're not as high functioning as a perfectly healthy individual would be. So, I think that it would be a reasonable thing to consider in a patient, certainly. And may help negate some of those refractive changes. It's a very interesting question.
Awesome. Well, thank you so much again. That concludes the CE portion of the evening. This was super interesting. I definitely learned a lot, and I know our attendees did as well. Thanks again.